Welcome to the Radiology Review Podcast, your on-the-go source for radiology education with your host, Dr. Matt Covington, a board-certified radiologist. Please follow the podcast on Twitter at RadRevPodcast. Send emails to theradiologyreview@gmail.com or visit the website theradiologyreview.com.
Welcome back to the Radiology Review Podcast. This episode is part 2 of my discussion of nuclear medicine renal imaging. I will make a free downloadable study guide covering the information in both episodes 1 and 2 available on my website, theradiologyreview.com. So go ahead and check that out if that is helpful for you. Let's go ahead and get started on the questions and answers for this episode. First question. For the clearance phase of a MAG-3 study, what is the T1/2 as well as the 20/3 and 20/peak ratios? The clearance phase of a MAG-3 study evaluates for renal artery obstruction by evaluating the ability of urine within the renal collecting system to enter the bladder. With obstruction anywhere along the urinary tract, delayed clearance times will be detected. The 3 metrics I mentioned all have different ways of assessing for adequate clearance of radiotracer from the renal collecting system. The T1/2 is the amount of time it takes for half of the radiotracer to clear from the renal collecting system, with a normal time of approximately less than 10 minutes. The 20/3 ratio assesses the peak count in the renal collecting system at 20 minutes compared to the peak count at 3 minutes. So essentially, you are evaluating how much urine has emptied between 3 and 20 minutes and then taking that 20/3 ratio. The 20/peak is a similar idea that simply compares the peak count again at 20 minutes divided by the peak count in the renal collecting system at any time, which would typically be the count at the beginning of the clearance phase when renal collecting counts are at a maximum. Of these, the most likely to be tested, in my opinion, is the T1/2, which is the time it takes to clear half of the total counts from the renal collecting system. So for this, to make sure everyone understands, you take the counts at the beginning of the excretory phase and you simply detect how long it took to clear half of those counts, and that is your T1/2 time. A common value considered normal is less than 10 minutes to clear half of the counts, your T1/2. Next question. Why may Lasix be given as part of renal obstruction evaluation on a MAG-3 study? If the renal collecting system does not empty within normal limits, Lasix is then given to help determine whether the delayed clearance is simply due to a dilated renal collecting system that can simply accommodate an excess capacitance of urine, the so-called reservoir effect, versus a true obstruction that prevents the normal emptying of the renal collecting system. Following Lasix administration, more urine will be produced, and if the collecting system is patent, the radiotracer will readily clear from the renal collecting system in a normal post-Lasix emptying time. If the system is obstructed, however, the renal collecting system will fail to empty in a normal time frame, even with that Lasix drive. Next. What is the T1/2 cutoff in minutes that is considered to represent significant obstruction? Recognizing that there are different values out there that I have seen, in general, a T1/2 of 20 minutes or greater following Lasix administration is consistent with significant obstruction. A T1/2 between 10 and 20 minutes is considered by some to be indeterminate, by others to represent a mild degree of obstruction from 10 to 15 minutes, and a moderate degree of obstruction from 15 to 20 minutes. A T1/2 of under 10 minutes is typically considered normal. To keep this simple for board exam purposes, you'll probably be okay if you just simply remember that a T1/2 less than 10 minutes is normal, between 10 and 20 minutes is gray or indeterminate, and greater than 20 minutes is confirmed definite obstruction. Next question, true or false? Renal failure can mimic obstruction on a MAG3 study. The answer here is true. Poor renal function can result in insufficient urine production to clear the radiotracer from the renal collecting system in a normal time frame. Poor renal function can often be detected by abnormal flow, cortical, and clearance phases on a MAG3 study. Again, if your kidney is not working well, all 3 phases of the MAG3 study may end up being abnormal. Note that severe obstruction can also result in very poor renal function. So in cases of severe renal dysfunction and corresponding hydronephrosis, a MAG3 study may be limited for evaluation of degree of obstruction. It simply may be confusing whether the poor clearance is due to the extremely poor renal function or if there is obstruction that may be contributing to the extremely poor renal function. Note also that a neurogenic or obstructed bladder, such as with severe benign prostatic hypertrophy or an obstructing mass, can also create sufficient back pressure in the renal collecting system to manifest as renal obstruction on a MAG3 study. Next, what is the MAG3 protocol for evaluation of suspected renal artery stenosis? This is one of the topics that I found confusing when I was studying for the ABR core exam. To help perhaps keep this less confusing, I'm going to simplify this. The key when considering evaluation of suspected renal artery stenosis with MAG3 for board exams is that you are going to use an ACE inhibitor, often captopril, as part of the examination. You will first perform a standard study with no ACE inhibitor. You will then repeat the study following administration of an ACE inhibitor. Without getting into the details of the physiology, if you remember that no difference between the 2 studies means there is no renal artery stenosis, that will help you stay on track on multiple choice questions. On the other hand, if you see a worsening of renal clearance in one kidney after administering the ACE inhibitor, that is consistent with renal artery stenosis. Renal artery stenosis would be expected to show a unilateral process and not a bilateral process. A positive MAG3 exam for renal artery stenosis is asymmetric worsening of renal clearance following administration of an ACE inhibitor. This is a highly tested concept, so make sure you understand this. Next, what are ways to distinguish between acute renal transplant rejection and acute tubular necrosis on a MAG3 study? A hallmark for acute renal transplant rejection is impaired blood flow, whereas acute tubular necrosis has normal renal blood flow. On a MAG3 study in the flow phase, you would expect to see delayed perfusion to the transplanted kidney in the setting of acute rejection and normal renal perfusion in the setting of acute tubular necrosis. Both entities would be expected to show delayed cortical transit and excretion. Remember that both of these entities can occur in the immediate postoperative period. The classic appearance of ATN is normal renal perfusion, followed by retention of radiotracer in the renal cortex, as renal function is not sufficient to clear the radiotracer from the renal cortex for excretion. Next question. What are differential considerations for postoperative peri-renal transplant fluid collections? If you see a fluid collection surrounding a transplanted kidney, the most common differential considerations include a postoperative hematoma, as well as a urinoma and a lymphocele. Next, true or false? A urinoma typically shows robust activity on MAG3 blood flow imaging? The answer here is false. A urinoma typically shows up on more delayed imaging on MAG3, most notably excretory phase imaging, as a peritransplant kidney fluid collection. If you see tracer uptake on a MAG3 study, the peritransplant kidney fluid collection is most consistent with a urinoma, as the tracer is concentrated through the kidney into the urine. For these types of questions on a board exam, the time from surgery at which the fluid collection develops may also be helpful. Postoperative hematomas are typically present in the immediate postoperative state. Urinomas can take a week or so to develop, at least several days most commonly, and become clinically evident at that point, and lymphocils take even longer, perhaps even a month or two, to become clinically evident. To help remember this, I think of the rate of fluid accumulation and remember that urine would be expected to accumulate more rapidly than lymphatic fluid. Therefore, a urinoma would be expected to manifest in less time than a lymphocyl. Next question. What is the critical organ of Tec-99m DMSA? The kidney is the critical organ for technetium-99m DMSA. Remember that technetium-99m DMSA binds to the renal cortex and is used for renal cortical imaging. Basically, the tracer gets to the renal cortex and essentially stays there for quite a while, as opposed to other nuclear renal imaging agents that pass through the kidney into the urine. Therefore, the critical organ for technetium DMSA is the kidney, and the critical organ for other nuclear renal imaging agents such as technetium MAG3 and technetium glucoheptanate are the urinary bladder. Final question for this episode. What are primary clinical uses for technetium-99m DMSA? Technetium-99m DMSA is probably most commonly used for pediatric renal cortical imaging in the setting of acute pyelonephritis evaluation. On such a study, look for areas of focal decreased uptake, which can be solitary or multifocal, to confirm areas of pyelonephritis and/or renal scarring. If the patient has acute symptoms consistent with acute pyelonephritis, imaging findings of focal decreased areas of uptake are consistent with acute pyelonephritis. On the other hand, if the clinical history is that of prior recurrent pyelonephritis, imaging findings would then be most consistent with renal scarring if you see solitary or multifocal areas of decreased uptake, with something like a renal mass or masses not strictly excluded. If concern for renal masses is present, other imaging such as ultrasound or MRI may be necessary. Additionally, technetium DMSA can be used to evaluate for renal mass versus column of Bertin. I think I said that right. It is spelled Bertin. This is a column of normal renal tissue, the column of Bertin, that most commonly is seen in the mid-pole of the kidney, and this is essentially a normal anatomic variant that can look like a mass, especially on renal ultrasound imaging, and this is sometimes even referred to as a pseudotumor. A column of Bertin, as constituted by functional renal tissue, will show uptake similar to the renal cortical tissue elsewhere, whereas a renal mass would be expected to show less uptake or be cold, particularly on a board exam question. I hope these few episodes on renal imaging pertaining to nuclear medicine were helpful. Again, I am posting a free downloadable study guide on this topic, which is available on my website, theradiologyreview.com. Thank you to all of you who are listening and who have shared this podcast with your friends in radiology. Keep up the good work and study hard. Remember, you have to study really hard to succeed on radiology board exams and nuclear medicine board exams, so prepare to succeed. I will catch you on the next episode. Content of this podcast is provided for informal educational purposes only for radiology trainees and radiologists. Medical practitioners, please make your own independent assessment before suggesting a diagnosis or recommending any course of treatment. This podcast should not be used for self-diagnosis or self-treatment and is not a substitute for independent professional medical care. Please consult your own physician regarding any diagnosis, imaging interpretation, or course of treatment.